Welcome everyone to the Aurora Health Alliance Behavioral Health and Kids Interest Group meeting. My name is Laura Don. I am on the AHA board. I'm also the Regional Health Connector for Arapahoe County. It's nice to see some familiar faces. Our first speaker is Elizabeth Coan from Children's Hospital, and she is going to speak a little bit to sort of kick us off and speak to what is autism, how does it present. She works closely with this population and families with children experiencing autism. And so thank you, Elizabeth, for being here with us, and I'm going to turn it over to you.
Yeah, I'm Liz Coan. Thank you so much for having me. I'm a psychologist in developmental peds at Children's Hospital. So my clinical work is a lot of autism assessment and some treatment as well. And then I also do a lot of community physician education and training around autism spectrum disorder. So you guys tasked me with what is autism, the different ways that it can present, and destigmatizing the diagnosis in 15 minutes. So if this happens, I am just fabulous at my job. Okay, so we'll see how much we can get through. There are lots of slides here, so some of them I'll just kind of run through, and hopefully you guys can distribute the slides afterwards so people have them for their reference. So I'll try not to linger too much. But yeah, so firstly, just some basics. Just talking a little bit about the prevalence of autism. This is the world's fastest growing developmental difference. And actually, these are outdated slides. So I've done a little fancy animation here to get us up to speed. But the most recent statistics that we have from the CDC are that we're looking at diagnosis of autism in 1 in 44 people. So this is approaching 2% of the world's population, which, as everyone knows, has just increased and increased over the last several decades. The autism prevalence can vary a little bit state to state. We're a little bit lower than kind of the average United States prevalence rate here in Colorado. But we're looking at more than 3.5 million Americans that live with autism spectrum disorder. When I'm doing my evaluations at work, I often ask families if they've heard of autism spectrum disorder before, which increasingly, right, families are saying yes to that question. It's something they're familiar with. But the second question I ask is, do you know anyone who has this diagnosis? And whenever families say, no, we don't know anyone, I have kind of a secret smile to myself, because I think, yes, you do, but you just might not know that you do, right? Because that's how prevalent this diagnosis is. So just some kind of fast facts about autism. We do see that autism is diagnosed in boys quite a bit more often than it's diagnosed in girls. 10 years ago, the conversation in the field about this was very different than it is now. I think 10 years ago, we were really thinking, geez, why is it happening in boys so much more than in girls? And now we have a different way of thinking, which is, why are we so bad at diagnosing autism in girls? Because we really don't think that this is actually a sex-linked difference at all. It's just that the presentation of autism can look really different in females. And we are not as good at naming it, especially when girls are young. We do see some disparities in terms of just access to the diagnostic process. So white children are still more likely to be diagnosed with autism than minority children. And minority children are often diagnosed later. Again, this is not a reflection of any true kind of racial or ethnic difference in the prevalence of autism, but just more of an access to services commentary. In the United States, most children are still being diagnosed around 4. That's the average age of diagnosis, which we think is rather late, because really all of the research now is kind of convincingly pointing to the fact that this can be reliably diagnosed as early as 2, and that's even a little late. We have studies coming out now that are talking about reliable diagnosis at 18 months, some as early as 14 months. So we really are pushing early identification and treatment. This is a highly heritable presentation. So we know that parents who have kids that have autism have as high as a 20% rate of having another child with autism. And if that second child is a boy, it's actually a little higher, it's 25%. And there's lots of questions that we get all the time about why are we seeing such an increase in this prevalence rate? Why are we seeing so much autism? And the question is there really more autism, or are we just better at diagnosing it? And I think the easiest answer is that it's a little bit of both. We're also more familiar with this diagnosis as a society. So I'm just going to throw up some of my favorite faces here and seeing if anyone might recognize who these characters are. But starting over here, this is Max. He was from the show Parenthood, which was, it was like the original This Is Us. I think it was like 10 years ago. But Max played a 10-year-old boy with Asperger's. We have Sheldon from The Big Bang Theory. That one is usually pretty familiar to people. This is The Good Doctor, which is a newer show. And this is Michael from the Netflix show, Love on the Spectrum. If anyone has not watched Love on the Spectrum, I highly, highly recommend. Just knowing that Michael exists in the world makes me happier day to day. So I would check that out. And then, of course, we have Julia up here, who is Sesame Street's autistic character. So we are becoming a lot more familiar with this diagnosis. We see representations of it in mainstream media, and we are moving, hopefully, to a place where we are not having actors play people with autism, but we have autistic actors who are actually representing those characters. We're getting there. Okay, so quick here. So the DSM-5 criteria for autism really breaks down two main categories where we're looking for differences. The first is differences in social communication skills, and the second is differences related to restricted or repetitive interests and behaviors. That's also where we see behavioral rigidity kind of show its face, and sensory differences as well. So just to highlight these a little bit more, I'm not going to read them line for line for you guys, but it is important to note this because autism is a behavioral diagnosis. It lives in the medical world, but there are no medical indicators, for instance, like a gene that says this is autism. It really is based on whether the behavioral symptoms are present. So when we are doing our diagnostic evaluations, we are looking for these differences throughout our time with the family and the child. So for this first category of social communication differences, we really need to see 3 out of 3 of these criteria. So differences in social emotional reciprocity, differences in nonverbal communication and those behaviors, and then differences in what kind of relationship maintenance looks like and interactions look like with peers. Again, I'm speeding through, so we can hit a lot in questions later too. The second category where we look for differences is in that restricted and repetitive patterns of behavior category. And we got some of our kind of frequent flyers over here. For this subset of symptoms, we're just looking for 2 out of the 4 criteria that's listed here. So it doesn't have to be all 4 of the things that are mentioned, but just 2 of the 4. And I'll just throw this up here. This is our newest Thomas the Train character. He's an autistic train. We just learned about him, I think, probably within the last month. But this is fabulous news because Thomas the Train needed an autistic representative for decades, I think, given how popular he is with a lot of the kids that we see. And they have a version of this show that's being shown in the UK and a version here in the States. And both of the actors that represent this tank engine have autism, which is really, really cool. So just some other things to mention that I think is really important in terms of how we provide this diagnosis is that along with the criteria that I just highlighted, we also need to make sure that we're documenting that symptoms have been present across the developmental lifespan. Autism is not something you get for your 10th birthday. The diagnosis may be something that comes to you later in life, but really part of our assessment process when we're assessing older kids, teenagers, or adults is to really make sure we have a robust documentation of these social differences and the presence of those rigid or repetitive behaviors from early in the developmental trajectory. The key here is that they may not fully manifest until the social demands increase to such a level that we really show the deficits. And I'll talk about that a little bit coming up here. The other thing that's really important, as is every diagnosis in our DSM, is that we have to see that the presentation of these symptoms are getting in the way in some degree, right? Preventing the child from being able to access other things in their life that might be meaningful or important for their overall development. And I think it is key, as many of you might know, we had a big diagnostic shift in 2013, where some of our previous categories that were recognized under the autism spectrum umbrella, like pervasive developmental disorder not otherwise specified and Asperger's syndrome, those were removed from the DSM in 2013. But it did include this kind of caveat that said, any of those diagnoses that were well established before the change automatically get the label of autism spectrum disorder. Around 2013, 2014 in developmental peds at the hospital, we were seeing a lot more of these referrals that were families who had kids who carried those previous nomenclatures beforehand and were coming to see if they met full criteria for autism. That is less common now that that's happening, but that was something that did happen a lot right after that diagnostic change. So these are the ones I'm going to fly through, but I have included some red flag slides here that just highlight some of the differences that show up at various ages and stages in development that can be indicative of a possible diagnosis of autism. Kind of the ones that show up here, the birth to 2 years, I feel like these are the ones that most of us are most familiar with as a society. We have screening tools like the MCHAT that should be distributed at every 18 and 24-month visit when you take your kids in for a well check. That are hitting on these things here. So they're a little bit more familiar in terms of autism criteria that people just know a little bit better. And these are also kind of, for lack of a better word, more of the stereotypical symptomatology. So these are the things that really, I think, are well known and looked for in kind of a systematic way. And so these tend to be the ones that really represent that stereotypical or classic presentation of autism, which, as we know now, the spectrum, I think, is bigger than it used to be. And so sometimes the differences are much more nuanced than what we might recognize during this period of time. So again, remembering that in the United States, autism diagnosis, the average age of diagnosis is around 4 years old. So again, it's some of these bigger things that might stand out around this time frame to kind of afford an earlier diagnosis. We see difficulties with friendships, trouble with conversations, differences in prosody, how the speech actually sounds, and its variability in tone, pitch, and inflection. Focused interests, differences in creative play, and difficulties with emotion. Just some things to think about as I kind of allude to the fact that the autism spectrum has gotten a little bit bigger, I think, in the past decade, is kind of the understanding that when we're considering autism in the later years, sometimes there's a basic assumption that the child has kind of a good collection of surface level skills that have allowed them to kind of get by up until the time when we might see them in clinic. So oftentimes this means those 3 and 4-year-old kind of social skills. Some of our kids who have had kind of decent social skills at that age, when they move up into kind of upper elementary, middle school, high school, is where we might see some more nuanced differences show up. So one of the things I'm always coaching myself when I'm seeing these kids in clinic to think about is not about presence or absence of skill, but truly about the quality of the skill, right? So that means when we're thinking about social communication skills, it means we're considering things like skill integration. For instance, even now on this call, when I can only see a few little people in their boxes, I'm using a variety of social communication skills to communicate and connect with you. That includes eye contact, facial expression, tone of voice, gesture use, all of these things are happening naturally and they're naturally integrated. So it's not like I'm sitting here thinking, now I will reference to Annie, right? Thanks, Annie, because I can see your face. I'm not thinking of all that, right? My skills are naturally integrated, and this is how they are developed in typical development. Sometimes with our kids, it's not that they don't gesture, it's not that they don't make eye contact, it's just that the quality of those skills looks a little different. So they're a little bit more rehearsed or a little bit more separate, right? So they're not kind of coming together in a naturally integrated way. And sometimes for our older kids, it's just about whether their social repertoire or behavioral repertoire matches the social environment, right? So a lot of the older guys that I see, and people have said, oh, he can't have autism, he's the class clown. He's always coming up to us, trying to make us laugh. And that's a lovely quality that really paints some social motivation. But he does it in the middle of math class, or when a friend is crying, or when his mom is in the middle of a conversation, right? So it's lovely that he has a good sense of humor, but what's missing is kind of the anchor of like, is this appropriate time to engage in that? Yes or no? So we're really looking at those nuanced things. Okay, so this is what it might look like in these older ages, between 5 to 11 years. We just see kind of more nuanced differences, right? So there could be struggles with perspective taking, or what we call theory of mind, difficulties with social reciprocity. I sat with a 10-year-old last week who was absolutely delightful. Every time I told him something about myself, he said, great. Wow. Right? He said it every single time. It was a lovely social acknowledgement, but what was missing is any follow-up question, right? Ask me anything more. How are we going to build on this? How are we going to keep this conversation going? And he had learned very good, polite social acknowledgement skills, but really was missing those extra pieces that would build, right, our conversation into a more robust exchange. I just pun humor, literal humor. Oh, I live for it. And the autistic brain also does. So a lot of kind of concrete applications of humor. And again, just more nuanced presentation of differences. Okay, I'm probably like up on my time, right? I'll go really quick. I have 5 more minutes, maybe. Okay. So I was next tasked with destigmatizing autism, which is something that I think we are all who are in kind of like the professional realm here are talking about this all the time. But a big part of destigmatization is just talking about it and naming it. I think for many, many years, and even when I go out to pediatricians' offices and I talk with them about naming autism early on with their patients, sometimes there are docs who have this kind of like, it's like Voldemort, right? It's like the name we do not speak of. We can't say it out loud. And unfortunately, I think that really builds the stigma and scares people to think that this is a diagnosis that, man, I had a physician a year ago when I did this education say, oh, but autism, it's such a debilitating diagnosis. And I said, I don't really think that anymore. Now, of course, there are some presentations of autism that have a very true kind of experience of disability that is associated with it. But there are other presentations of autism that really are not all bad news. And I think if we can start talking about that in kind of a confident way, that is communicated to the patients and families that we see. So really, it's talking about how we normalize the screening process. We do this for everybody because we know that autism is pretty prevalent. And the reason why we screen for this is because if we see signs for autism, we can put a plan in place that's going to help, right? It's communicating our confidence. It's communicating to the family that if this is indeed present, we are here to help you and we know the path forward. I've put a lot of kind of bullet points in here too, and just for you guys to kind of use as might be appropriate or comfortable for you. when I talk to families about these differences, I find that it's really helpful to use the family's language to kind of create those points where we can join together. A lot of times, if you start out the gate with a family and say, I'm concerned with autism, the kind of bigness of that word can scare families away. But I do have families that come in saying, oh, I don't think she has autism. She's just really awkward, right? When we go to King Super, she wants to hug all the people in the checkout line before we leave, right? And that's a good opportunity for me to say, yes, I agree that that's awkward too. And it actually is kind of common to see older kids with autism engage in social behaviors in a different way, kind of like you're describing. Sometimes if you're in a setting that uses a standardized screen like an MChat, you can blame it, right? You can blame the screener to open the conversation, and sometimes that's most comfortable for folks. But the other thing that I think is just most powerful with families is to use what you're seeing when you're sitting with them as the way to anchor the conversation. And I've been in the middle of conversations with parents where I interrupt myself and say, oh, look, actually, I've never seen him do this before. So he's spinning around in a circle and jumping up and down and flapping his hands. Can you tell me how you understand this? What is he communicating right now? To bring the family into the differences that you're recognizing and name them in a new way. Name it. Use the A word. Okay, so here are just, again, some kind of basic scripts that can help to anchor this conversation. Because we're seeing some of these differences and kind of insert the family's language here, I think we should look into the possibility of autism. Have you heard about this diagnosis before? Do you know anyone who has it? And then, of course, because that can open quite the can of worms, I think it's really nice to be able to talk knowledgeably with families about the spectrum. This is a graphic that the CDC put out years ago, and I actually will bring this out with families sometimes just to highlight that different presentations of autism may mean that people have different kind of skill presentation in each of these sliding scales, and they can still have a diagnosis of autism. And sometimes kind of likening that to other things that might be a little bit more familiar, such as there are some people with anxiety who can't leave the house because they're so anxious. There are other people with anxiety who work full-time jobs and it doesn't stop them from going through their day-to-day. Autism is similar. Sometimes there are pieces of the presentation that may be presenting more obstacles, and sometimes there are pieces of the presentation that really aren't getting in the way. And then I wasn't quite sure of who the audience would be today, but I hope that if you're working closely with patients and families, or clients and families, whatever the terminology is that fits you, that you're developing a relationship with these people that you're seeing, and you can use that relationship to really communicate your care for the family and your comfort with this diagnosis. And I think if you're doing that in a comfortable way, and if you truly believe in your heart that this diagnosis is not all bad news, people will believe what you're saying to them. So I've provided, again, some scripts here that you guys can kind of wordsmith to your liking, but just something to fall back on to encourage you to be having those conversations earlier with families in a comfortable and confident way. That's it. I did it. Okay, thank you so much.
Thank you so much, Dr. Coan, for sharing your wisdom and positive energy and all of that. Really, really appreciate it. I am excited to introduce Ann Brack. Ann is on the Tri-County Health Department nursing team, and she helps families navigate the complexities of autism and is a wealth of knowledge in terms of resources. So I'm going to turn it over to Annie.
Good morning. Good morning. Again, my name is Annie Brack, and I'm a nurse with Tri-County Health Department. Thanks for having me today. I've been invited to come and talk to you about the work that I do with families. And I wanted to share with you the process of navigating some of the basic resources for children who have autism who live in the Aurora area. Every family situation is different, and every child with autism is an individual. My approach is family and child-centered, combined with the knowledge and experience that I've gained from working with families. Next slide, please. I work in a program called HCP, and that's a program for families who have children with special health care needs. I offer a service called Care Coordination, which provides families with education and guidance and support to navigate the complex world of services and supports for children who have a disability or a delay. Those kiddos that are eligible for this program are kind of just defined as any child who visits the doctor more often than any other child their same age. They don't have to have an official diagnosis, and we provide these services at a cost to at no cost to families. So it's a free service. Also, over the years, I kind of understood that term care coordination really wasn't ringing with families, but that they understood that they were running into a lot of barriers and a lot of challenges out there. So I kind of termed myself as a barrier buster, and that they understood that I was a bridge. I could be a bridge for them, for their family, between the services that they needed and wanted for their kiddos and that access to those services. Next slide, please. Next slide. These are the things that I want to cover today. The things that I think are, just kind of really basic and foundational for families. Early intervention services, the diagnostic evaluation, the Medicaid waivers, Social Security insurance for children with a disability, and parent support groups. So I'll be covering those. The first one, and I kind of started because this is so important, is early intervention. Early intervention is used to describe the services available to children from birth to age 3 who have a developmental delay or disability. One of the most important reasons to be taking your infant for regular well checkups is to discuss developmental milestones and concerns. When a parent or physician believes milestones are not being met, a child can be referred for early intervention services. Without developmental skills in place, a child with autism will choose anything that seems to work to get their needs met. And often this results in maladaptive behaviors. And those behaviors are very hard to unlearn because they've worked for that child up until now. But fortunately, brains of young kiddos grow fast, so they can learn new things more easily than older children. So a referral early to this program is so important. But currently, there's an underutilization of early intervention services for children who have autism. To refer, you can self-refer, contact your local community-centered board or any provider. A parent can also contact online the early intervention folks, and that they will reach out to them. Early intervention will reach out to them and make an appointment for an evaluation. Early intervention services are paid through a variety of funding sources, including Medicaid, CHP Plus, private health insurance, and state and federal Part C funds. Services may be scheduled in the child's home, daycare center, a relative's home, or a community setting. Next slide, please. The diagnostic evaluation, and Dr. Coan, this is her specialty. This is what she is wanting to offer for families, because it's that formal diagnostic evaluation. And as she kind of referred, it can be done as early as 18 months. Doctors look at the history of a child's development and behavior, and using that neuropsychological evaluation can make an autism diagnosis. Those first initial concerns seen by parents, family members, or providers may look like delays in language or movement skills. But the other characteristics that are seen in children with autism, again, just like Dr. Coan had mentioned, include delays in social skills and behaviors or interests that tend to be restricted or repetitive. The earlier a diagnosis is made, the earlier a child can start receiving services specific to the needs of that individual child. And again, I kind of feel like I'm, kind of saying the same thing that Dr. Coan said. Children with autism grow into adults with autism, and they can all enjoy friends, activities, and have lives with meaning and purpose. But with early diagnoses, supports, and intervention, they can achieve their highest potential. Next slide, please. I've been a little sick, so I'm not used to talking, so I'm sorry about if I have a little froggy in my throat. So this slide's going to cover Medicaid waivers. And then when I was talking earlier about the early intervention services, I may have mentioned a term that you might not be familiar with, which was Community-Centered Board, or CCB for short. CCBs are the gatekeepers, if you will, for the Medicaid waiver services. Children with autism often need 24/7 supervision in order to stay safe and healthy. And a Medicaid waiver is an addendum to Medicaid insurance that provides additional coverage for the needs of a child with autism. Needs may include respite care so that caregivers can take a break, home accessibility adaptations, funding for summer camp, or becoming a paid family caregiver for your child. All of these services can be covered under Medicaid with the waiver program. And the most common waiver that serves children with autism and their families is the CES waiver, or Children's Extensive Support Waiver. It's usually the waiver chosen because it can address supports for behavioral concerns. Children with autism qualify for CES Medicaid waiver services through a functional needs assessment and a financial assessment done by the CCBs. And the CCBs are responsible for the community services for children and adults with intellectual and developmental disabilities. A family chooses the CCB that provides services in the county in which they reside. And that's why I've listed here the two CCBs that serve the counties in which Aurora kind of crosses right there. Funding comes from both federal and state general fund revenue. Next slide, please. Social Security insurance. I think a lot of folks think that Social Security is just for our older population, but there is Social Security for children with a disability. Disability and financial guidelines need to be in place to qualify for those benefits. And the medical documentation needs to prove that the child with autism has a medical impairment that has lasted or is expected to last 12 months. And also the child experiences marked and severe functional limitations, including an emotional or learning problem. And I took that definition directly off of the Social Security official site. The problem arises because both words marked and severe are subjective terms, and any one person can define those words to mean something different to them. That's why providing professional documentation is so important. And I've always told parents more is more in this instance. Collect documents from therapists, doctors, teachers, anyone who has a history of interaction with their child where the behaviors around autism were referenced. And then I always tell parents, appeal, appeal, appeal. It's kind of known in my world that the first application is always denied. And parents get, discouraged and give up, but maybe you need another piece of documentation, or, So I always tell parents to just keep trying. Next slide, please. Supports for families. Now I've put this kind of as my last slide, but I can't really emphasize this enough, that families, it takes a village, and families that have kiddos with a disability, and especially families that are raising a child that has autism, care for that kiddo is 24/7. And I don't know that any of us, unless you are a parent that has a kiddo with a child with autism, understands the amount of energy that it takes. These are 3 support agencies that kind of focus on different needs for families. The Peak Parent Center, their support is related to school and education. Family Voices offers support with navigating healthcare and service systems. And then there's Parent to Parent, which is a network of families who have children with special needs. There's several others, Autism Community Store and also ARC are also some of those out there, some of the support for families. Next slide, please. Here's kind of the contact information for some of the resources that I kind of referenced in my talk, how to reach the CCBs, both in Arapahoe County and Adams County, how to self-refer if, those are that's the way to contact them. If you're wanting, your questions answered or assistance navigating Medicaid, Christy Blakely is the executive director, and she's the gal that you want to reach out to at Family Voices. She's, that's on their website. She wants you to reach out to her. She's a lovely individual. And Parent to Parent for connection to other families. So contact Ability Connection Colorado. Next slide, please. And you can contact me. I know Tri-County, I know you've heard Tri-County is dissolving at the end of this year, but my teammates and I are still offering information and resource referral for families. So, there's my information right there, both my email and my phone number. Thank you. Thank you so much.
Thank you so much, Annie. And thank you for all the work you do with families in our community. I know that is like your heart is in it. One clarifying question. So are you all taking new referrals?
We are not providing care coordination for families. So not those long-term. We've only got a couple months here left, but we are taking referrals to offer information and resource referrals. So we're not turning families away.
Great.
We also will work with providers. If they are wanting, a name or a place as well for a referral, reference, or resource. Yeah, we're still offering that.
I'm going to kick it over to our next speakers. We are delighted to have Mary and Jayne from Child Find here today to kind of tell us a little bit about Child Find and what resources are used and what's needed. So Mary and Jayne, off to you.
So I'm Mary Morin, and I am the Child Find Specialist with the Colorado Department of Education. I'm here with Jayne Dougherty, who is the Child Find Coordinator for Aurora Public Schools. And we were asked to talk a little bit about Child Find. I'm going to do a brief overview of Child Find statewide, and then Jayne can talk more specifically about local. So Child Find is part of the Individuals with Disability, or IDEA Act, which is a federal regulation. It requires that for all states to identify, locate, and evaluate children with special needs. We are preschool Child Find, as you heard in the previous discussion. Early intervention and your community center boards are doing the 0 to 3, and Child Find with the school district or BOCES is responsible for preschool age Child Find. It's important that you understand that our job is to identify children with disabilities and then make sure that they receive a free and appropriate public education, which includes a special education and related services that they would need to access the general education curriculum. Every school district or BOCES or charter school association within the state has a child find coordinator. That person will be managing and overseeing child identification for 3 to 5 year olds, also for those late 2-year-olds that are moving up from early intervention into preschool age. Anyone can make a referral, just like you heard previously, to Child Find. We often get referrals from medical clinics, from Part C, that's early intervention, family members, social services, childcare. Anyone, again, can make that referral. The time to make a referral is when you see a developmental or behavioral delay. It's important, since I know there are a lot of medical providers on this call, for me to make the distinction between a referral and an order. If a physician is making a referral to, let's say, physical therapy in an outpatient setting, they're going to say, evaluate and treat. And that becomes, the PT can start evaluating and treating based on medical insurance. However, in the school system, a referral to Child Find is a referral for the system to look and see if the child will qualify and has the need for services that would help, without which they could not access the general education curriculum. So it's a different level of qualifying for those services. So you need to need special education supports to access general education. If we get a referral that says evaluate and treat, we're obviously going to do the same work on getting to know the family, understanding the concerns, and seeing how to move forward with that individual child and family. If the child's already in a publicly funded preschool or K-12, then what you'd want to do is ask your tell the family to bring up their concerns to the school. So a parent does not need to provide written consent for a referral, but if you want information back from the referral source, then having that release of information, and I think Jayne will talk about what her referrals look like, and if that release is built in. You should have the parent be aware. I know in my work, when it's something the provider thinks about and then later writes a referral to, but didn't have a good discussion with the parent, that's going to be the parent that doesn't respond to being reached out by Child Find. So it's really important that providers have a relationship with their local Child Find coordinator. And I know in these urban areas, you might deal with more than one Child Find coordinator. So unfortunately, you have to learn more than one procedure, maybe deal with more than one form. As much as you can, it will speed the process and make a more thorough process to include with your referral the reason, your specific concerns, any developmental screening that happened in your office. I have the website here that will bring you to this picture down here, and on each of these areas you can find by school district who the Child Find coordinator is. Now, I'm going to hand it over to Jayne. She can talk more specifically about Aurora and autism referrals as well. I'll stop share now and you can see us again.
Hi there. Thank you for having me join your meeting today. In APS, as Mary had said, we get referrals from parents, Department of Human Services, we get them from medical providers, and then we also get the C2B referrals coming right from developmental pathways and do the coordination of moving a child, if with parent permission, from a Part C IFSP and doing an evaluation to see if they're eligible for special education and have an IEP through the Part B services. So for referrals that come to us, we generally gather basic information from parents, certainly of the concerns, try to look at the referrals at length to see what's provided. And then we start with having parents come bring their child in and we do a screen on the child. We do a developmental screen. We will do hearing and vision screen just to make sure we know exactly what providers need to be on the evaluation. And during that screen, then also we're gathering a lot of health information from the families. And as Mary had suggested regarding gathering additional health information in that release, our nurse on Child Find, if we need further information, she will get parent signature and do a release of information, whether it's for children's or doctor's offices, other providers. And we will certainly look at all of that information that's gathered as well. And then we will move to an evaluation for a child based on what the screen had said. Now, there's some kids certainly that will come to us that don't need to go through an evaluation. We find that developmentally they're right on track, and then we try to share out some information and strategies with families to support them working with their child on their own. And then we also provide them information for what we currently have now, which is our Colorado preschool program, which is the free preschool for students that have risk factors. So we try to give them some additional options for preschool. When a child, we suspect that they may have a disability and we move to eval, certainly for kids that are coming with concerns, the family has concerns or doctors have concerns for autism, what we're really looking at is gathering this body of evidence. We do a transdisciplinary play-based assessment with our team. Typically we'll include the special ed teacher, speech language therapist, OT and or PT, our nurses involved, and what we're really looking at, and our mental health, we have a school psychologist that we also bring in, and they're all looking at discipline-specific assessments along with the transdisciplinary play-based assessment, as well as doing observations. We gather a lot of information from families because they know their child best, and get some historical information on development for the child. We do, when the family comes in with the child, we really try to look at providing some unstructured play time to do observations to see how the child is functioning and engaging. And then we try to do a little bit more of some structured play to see the response. So we're really looking at a variety of developmental areas. As far as academic, we're going to look at the sensory components, motor components, play skills, communication, both expressive and receptive language, and then also look at their social emotional development as well. We certainly take into consideration all of the health information that families provide as well to help to try to provide support for the families. So we typically will do evaluations, especially for children that we suspect that may have autism. We may do 1 or 2 appointments. Sometimes the 2 appointment we need to do if we need to make sure we have our body of evidence gathered. Sometimes it'll be a virtual appointment just to see them in a different setting, or we may bring them back in person as well. And again, we kind of let the family dictate a little bit based on their circumstances and the child, how much interaction they can take, evaluation time and interaction they can take at that moment, whether it's better to do it in 1, 2, a variety of circumstances. We really take into consideration too with children with suspected to have autism, what are the cultural differences of the family, because we do certainly in Aurora have a lot of families with from different cultures, different languages. So take that into consideration as well when we're working with families and gathering information to make sure we're really understanding what's the expectations as well. And we're trying to look to weed out what are some cultural differences, language differences, behavioral expectations for kids to try to make sure what we're looking at truly is an autism educational diagnosis, that would be most appropriate as opposed to a developmental delay. If we feel we do have enough body of evidence, we certainly will make that educational diagnosis. If we don't, it may be that the child will attend preschool. We may decide that they fit under the developmental disability, meet that criteria, and they'll start in school. And at some point during their preschool process, that team working with them may say, you know, I think we need to do a reevaluation. We really need to look at this other criteria that's sort of making sense. We suspect the child may have autism. So certainly if it doesn't mean if they don't have an educational identification of autism when they enter school, it doesn't mean down the road that they won't get that, if that's what's appropriate. We certainly try to provide preschool services for children in the least restrictive environment, and make sure, since this is their first opportunity typically in school, make sure they have opportunities with typical peers. We do have more specialized programs if the child really needs some more structure and support beyond a typical classroom, but we're definitely geared toward integrating students as much as possible with their peers and getting that experience and exposure in that preschool setting. So,
I just want to jump in and also say that whether or not that educational diagnosis of autism shakes out, if that's the right word, through the body of evidence, the services and supports offered through the child's IEP or special ed plan are going to focus on the areas of delay, regardless of the category of eligibility. So the fact that it might not be immediate, that there is that specific, not diagnosis, but eligibility, does not affect the alignment of services to delays. Excuse me.
Correct. And some of those things, areas we're looking at, really are looking at their communication patterns. We're looking at functioning in their daily routines, and some of that is based on parent report. Looking at their responses to various stimuli in the environment, interaction with same-age peers or adults, preferences, dislikes, and really we want to know during the evaluation from parents, are we getting a good picture of this child on a regular basis, and how they're functioning and how they're typically engaging or performing during the day. So once we gather all of that information, the team does meet and they analyze the data that's gathered. They're going to synthesize it, and then we meet with the family, which is part of that IEP team, to determine what eligibility category best meets the needs for this child. Where are they best captured under? Is it developmental delay? Is it the autism diagnosis? Do they also have a secondary disability of a speech language impairment? So we're really meeting with the family and kind of weeding through all the data we gathered and determining what meets the needs of the child's best. And from there, we'll develop the IEP and the services, certainly look at what accommodations a child may need and what are some appropriate goals, so the child really can be successful in our preschool program.
Thank you, Mary and Jayne. Any questions?
You invited me. Hi, David Keller, random pediatrician who's been trolling in the chat. I really appreciate all of these presentations, and I think you highlighted one of my least favorite spots in the system, which is the child who I suspect of having problems at 2.5 years of age. Because if I send them to early intervention, they say we can't enroll them because they don't have enough time with us. But it's a little, is it too early for child find, or can I send 2.5-year-olds to child find, or do I have to wait 6 months before I can send them to any place?
Right now, it's a funny term because I say preschool child find, because early intervention has, they are doing the evaluations for 0 to 3. So I'm not sure, they said there's not enough time. Is that what you just said?
Right. I mean, by the time I send in a referral at 2.5, by the time it works its way through the system, very often what is the answer I get is, oh, it's too late to do the evaluation because we won't be able to provide services. Just wait until they're 3 and send them to child find.
Yeah,
and
that hurts my heart.
It
there's a
hurts my
federal-
heart.
I'm
Well,
sorry, David.
It troubles me, but
Yes.
it's very often what happens. And perhaps they don't say it quite as directly as that, but that's the implication, is that they're not going to get to this they're prioritizing evaluations of other kids first because they have the chance of getting therapy under early intervention. So it's that 2.5 to 3 age group is often when we're picking this stuff up, which is where it becomes hard. Elizabeth, are you nodding your head to say, yes, this happens? Please back me up here.
Well, I have a positive spin on it, which is that I've met a couple families recently that are just under 3. And they were saying, we just did our child find eval, like we just got it done. Which I was like, that's fabulous. How did you manage to pull that off, right? Getting in right before 3. But it does impact our work, I think, too, at the hospital, because like what you guys were saying, a medical diagnosis of autism is different than an educational classification of autism. And so sometimes the best work that I can provide for that 2.5-year-old is to provide the medical diagnosis of autism, knowing that at 3, they're going to have a full developmental evaluation where they'll be able to capture some of the other kind of differences in development if they're going on to child find, which is really nice, right, when it's couched that way. But yeah, so I've had just the pleasant surprise recently of having some kids who got in right before 3 and were already set up with their kind of school classification moving into preschool.
Yeah, they can't start.
I do want to put out there that there's a federal regulation that an evaluation, and if they qualify, an IFSP, a family service plan, is required within 45 days of receipt of a referral for early intervention. So hearing 2.5 and we don't have time is something that, I'm going to leave you my email because I work really well with the state level early intervention. We work together all the time on system issues, and we really want to help. Now, I have heard at maybe 210 to say, it's going to take 1.5 months for us to do the evaluation, and then you're going to get a couple of weeks maybe of services. Do you want us to refer you over and get that preschool evaluation started so things can be in place by 3? And I understand if the parent chooses, oh yeah, I see that as reasonable. Hearing about it at 2-6, of course, there should be plenty of time to get services started. I think Jayne wanted to add.
I would agree too. I think if typically from the CCBs, if it's 45 days or less till the child's 3rd birthday, they often cannot get the IFSP done and put services in place in that window of time. So often I know they will send the child or tell the family, just go call Child Find in Aurora and we'll just do a Part B. So, it's nice to hear, Elizabeth, you saying that you've had some positive experiences. A family can call us at any time. We typically have that obligation if they're 2-6 to say, hey, you need to be connected with your community center board because you could potentially have some services in place to help support the child and then still have your Part B closer to the 3rd birthday. But certainly if it's, under 45 days or under, and the family comes to us, we'll do the evaluation. They can start preschool till they're 3, but they can have everything done and register and enroll and be ready to go on their 3rd birthday and start attending. And that's really probably the best scenario, is to really get them in and so kids can start on their 3rd birthday. So hopefully that's what you were kind of referring to, Elizabeth, of, certainly, even if a child is 210, we can still do the evaluation and get them in. 2-6, again, they should probably be going to the community center board to get those services and supports with the chance that they can get some prior to coming to us. But
early intervention is now centralized So do you find, David, that when you're calling the centralized system for referral, this is what you're hearing, or was it more when you would call the specific community center boards?
I would say that this is an experience over the last 3 years. So yeah, I don't know how this is working with the new system. I am very hopeful about that. I'm also really glad to hear that CDPHE is working on making referrals possible electronically, because I believe all fax machines should be stopped and ground into dust. I don't believe fax serves a useful purpose anymore. We should be doing this all electronically. So yeah, there's things they're doing to try and tighten the process. It's a really tough call, because I think for me, the thing I would like to see, frankly, is I'd love early intervention to help the family get into child finds. Not that child finds is difficult, but they can really help with that transition. I certainly don't expect them to be able to get in a ton of services in the course of 6 months.
Well, and there is a very prescribed transition process between early intervention and child find. Right now, anyone who's enrolled in early intervention by 2/6, their name and basic info goes over to the school district, and then there's a transition staffing that Jayne's team would join, and then lining up for evaluation. So I absolutely agree that even if there's less services that can be with a late referral to Part C, that service coordination and process into child find is worth the referral right there.
While we're waiting, any other questions?
I was just going to mention something, if I could, about the IEP question and autism, because I think that, I think a lot, and I put this in the chat as well, I think a lot of our kids who get a medical diagnosis of autism end up with an IEP. But in the state of Colorado specifically, the schools are really entitled to make their own assessment to determine what kind of supports are helpful within the school setting. And I bring this up because there are some presentations of autism that maybe were the old school Asperger's syndrome diagnosis, perhaps, of my 10 or 12-year-old who aces all of his academic classes. He is motivated to please, and he is a rule follower, so he's not a big behavioral issue in school. And often, not often, but occasionally these kids are the ones that really don't qualify for supports in school because they're kind of doing school pretty well. And so this has become kind of a newer issue for us in terms of trying to really advocate. And the phrase I always use with parents is, it's great that he's acing math, but we need him to ace lunch and passing time and recess, because we think those are as important skills for life and overall development as math is. And so often in our evaluations, some of the deficits or kind of difficulty areas can be captured when looking at kind of daily living skills or independent living skills. So we use adaptive measures to get a sense of that, because some of our guys who have a 140 IQ are not dressing for the weather and they are refusing to brush their teeth. And so sometimes that's where we can capture the discrepancy that then can make an argument for those support services. But that is kind of the example, I think, that I've come up on more recently in the last few years of these super smart guys with autism that really isn't interfering behaviorally in school, and having to advocate a little bit more for them to get appropriate services through the school system.
I would agree, Elizabeth, and I think that is something we do look at, use adaptive measures, certainly to look at kids even as young as 3 to 5, and also look at them functionally. How are they functioning, and what is their access and participation in school? Because sometimes it's that access and participation what's limiting them. They can do the work, but can they get to doing that work? Do they know what they're going to do? And sometimes it's those executive function skills that we see too as kids age. that we find challenging, but we certainly, any reports that we get from physicians with the medical diagnosis, we find very valuable, and certainly consider everything and reference them in the IEPs as well. It's a great supporting document.
And I would say right back at you guys, I feel like it is increasingly now it's almost, if I see an educational classification of autism has been documented in their chart, it almost is becoming one of our kind of distilled criteria to fast track them to an expedited assessment, which is a model where I shouldn't even say it out loud, that we're trying out. But because it is so frequent that if the school system has picked up on the differences that are associated with autism within the school setting, then I mean, overwhelming, I can't think of a time when I've disagreed. That has always been a really informative document in terms of informing the medical diagnosis that is likely coming.
That's great to hear.
Okay, awesome. So I'm Nicole, I'm with Trumpet Behavioral Health. I know a few of you, but not everybody. So I just wanted to kind of jump in here and see if you guys had some direction and guidance for us as far as like, a lot of times, so we do ABA therapy, obviously, the littlest of the littles, all the way through the lifespan. And we're also opening our severe behavior clinic in Aurora in January. So a more intensive model, shorter term. But with that, we do have pretty significantly long wait lists for school age children. But that being said, like we know with the research that the most significant gains can be seen in that, 2 to 5, 2 to 6 kind of age frame. And we have not found a way to like work the best that we can with early intervention and child find. And it's not like the program itself is, it's amazing. But I think sometimes like the families are just from feedback that we've heard is like, they don't even know they have a care coordinator of like, because they just get so much information. So what we're really trying to figure out is like, how can we best work with, the pediatricians with early intervention to make sure that none of those families are like falling through the gaps and kind of like a safety net kind of to like catch them, to make sure that they're like getting the information that they need, because of how critical that time is. We just want to kind of maximize it. And so I don't know, with having all of you here together, if you have any ideas for us on how we can, better partner, how we can either empower families, empower parents to, and really like distilling down, because they get so much information at that time. Like, what is the most important thing that we should be directing them to? Is it their care coordinator? Is it, because they get children's when they get their diagnosis, it's in there, but it's a big report, right? That feedback session is big. So, they're dealing with a lot. So just making sure that we can support families, that we're catching all of those kiddos, that we can have the biggest impact, which is that 2 to 6 year old range. I think that's my rant. Okay. Yep. Anybody?
So I wanted to kind of talk about the, and get some questions, suggestions, and recommendations of how I can support more Black, Indigenous people of color in the heart of Aurora around early diagnosis. Because what I'm seeing, and I'm sure that many of you have seen this as well, is that our babies, our Black and brown babies, are being diagnosed late. And when they are being diagnosed, they're being funneled into a category of a disciplinary problem. And then that's been leading to more incarceration, when in excess it was really that they were autistic and they didn't have access to the resources that they needed early. So how can I support you all? And how can we get more families in the heart of Aurora? So I work in 810, which is basically Colfax and Yosemite. I work all up and down the corridor. And so I'm doing a lot of work with families who are on IEPs but are not diagnosed with autism. But as a provider, I know that they do have autism. What do you think what are your recommendations? What are your suggestions? And what are you doing to reach into communities of color, and how can I support that?
So I think a lot of this has to do with how the conversation starts in well check visits in kind of the pediatrician's office. I think there are some, and we just recently had this Society for Developmental and Behavioral Pediatrics conference this past weekend. And or 2 weekends ago, one of the kind of conversational topics was this idea of the wait and see kind of terminology that I think pediatricians use early on, like, let's just wait and see. And I think it used to be kind of assigned more generally to boys, right? He's a boy, so we'll just wait and see. That's why he's talking late. But I can see how other kind of stereotypes that have existed in our society could also fold into that, right? So thinking about how to be on the lookout for things that are developmental differences earlier, and bringing that up earlier with parents. And so it's recognized in the pediatrician's office instead of as an after the fact behavioral issue, and being able to name that earlier. We have a lot of physician education initiatives that we have been running for the past several years to kind of help pediatricians feel more comfortable bringing this up. But this is, a nationwide issue that Black and brown families and children are getting the diagnosis later, and their access to services also looks a lot different, right? So treatment included, right? Not just diagnostic evaluations, but then ongoing treatment for there. So I'm a big advocate of like earlier conversation across the board in safe spaces that are not based on, that are preemptive, right? This is the screening that we do for everyone because this is a diagnosis that we know to be prevalent. So again, and this happens in some of my conversations with physicians too, these screeners that are recommended at 18 and 24 months are not supposed to be a reaction to developmental concerns. They are supposed to be screeners. Screeners are given across the board, whether there are concerns or not. Right? That's how they're supposed to be used. So really educating physicians to use them in that way and talk about them freely in terms of what they're looking to assess. I think that's part of it.
Thank you so much, Dr. Coan.
I just want to thank our speakers today, Elizabeth, Annie, Mary, and Jayne. Thank you so much. So thank you all so much for being here. We really appreciate it.